at least 6 months. The central problem in generalized anxiety disorders is a generalized anxiety leading to fatigue and reduced arousal, loss of concentration, lack of sleep, irritability, and even muscle tension. The presentation of generalized anxiety disorders, patients will present with psychological and cognitive symptoms such as excessive anxiety, worries that are difficult to control, feeling fed up or on the edge, poor concentration, or even the mind going blank. And they might present with physical symptoms of restlessness, fatigue, muscle tension, sleep disturbance, and irritability. Panic disorders are usually begin as a series of unexpected, spontaneous panic attacks involving an intense, terrifying fear similar to that caused by a life-threatening danger. During a panic attack, patients will often describe an overwhelming sense of doom, the fear of dying or losing control. Most times, they last about 20 to 30 minutes, with peak symptoms being in the first 10 minutes. And secondary to panic attacks, patients might eventually develop agoraphobia, which is usually fear to it's usually not fear to a marketplace or fear to open places where they might not be able to go out and might just want to stay in one place to prevent panic disorder from happening. So the central problem in panic disorder is an anticipatory anxiety and fear, which will eventually lead to worry about the panic attack and cause unexpected panic attacks or even phobic avoidance or behavioral changes. The symptoms include psychological symptoms of depersonalization, derealization, fear of losing control, fear of going crazy, or fear of dying, and physical symptoms of abdominal distress, chest pain or discomfort, chills, dizziness, lightheadedness, choking, hot flushes, palpitations, nausea, shortness of breath, sweating, tachycardia, trembling, or even shaking. And the next one we'll talk about is the social anxiety disorder, and is also known as SAD. It's characterized by an intense, irrational, and persistent fear of being negatively evaluated or scrutinized in at least one social or performance situation. Exposure to the feared circumstance usually provokes an immediate situation-related panic attacks, and adults with SAD usually recognize their fear as excessive and unreasonable. However, they are not able to overcome it without treatment. The central problem here is the social performance anxiety or fear, which will eventually create worry about the exposure and cause expected panic attacks, eventually leading to phobic avoidance and behavioral changes. Most people, in individuals under the age of 18, the duration of symptoms is at least 6 months. The fear of avoidance is not caused by a drug or other substance such as cocaine or a general medical or psychiatric disorder. The mean onset of SAD is during the mid-teens, and the rates are slightly higher among women than men and more frequent in the younger females. It's a chronic disorder with a mean duration of 20 years. The next one we'll talk about is PTSD. PTSD is a condition marked by the development of symptoms after exposure to a traumatic life event, and patients with this react to this experience with fear and helplessness, persistently relive the events, and tries to avoid being reminded of it. It can occur at any age, and the cause is variable. About 1/3 of these patients to have a poor prognosis, as 80% of them have concurrent depression or an anxiety disorder. So the central problem is anxiety due to re-experiencing, eventually leading to worry. It can cause poor sleep, reduction in arousal, and avoidance of similar situations. Like we said, going back to the brain, the hippocampus is the area where individuals' memories are stored. And therefore, in people who have PTSD, memories are stored in the hippocampus and can activate the amygdala, causing the amygdala in turn to activate other brain regions and generate a fear response. This is usually termed re-experiencing, and it's a particular feature of post-traumatic stress disorder. So what symptoms do they have? People who have re-experiencing symptoms will have recurrent, intrusive, distressing memories of the trauma, recurrent, disturbing dreams of the event, feeling that the traumatic event is reoccurring, such as that thereby having dissociative, such as dissociative flashbacks, physiologic reaction to reminders of the trauma. Avoidance symptoms they might have are of avoidance of conversations about the trauma, avoidance of thoughts or feelings about the trauma, avoidance of activities that are reminders of the event, avoidance of people or places that arouse recollections of the trauma, inability to recall an important aspect of the trauma, anhedonia, restricted affect, a sense of foreshortened future, e.g., the person doesn't expect to have a career, a marriage, etc. They can have hyperarousal symptoms leading to decreased concentration. They're easily startled, hypervigilance, insomnia, irritability, or angry bouts. It can be acute, it can be chronic, it can be of delayed onset. Acute symptoms will occur in less than 3 months. Chronic symptoms occur longer than 3 months. In chronic situations, the symptoms last for longer than 3 months, while in acute symptoms, it lasts less than 3 months. And those with delayed symptoms, the onset of symptoms is at least 6 months post-trauma. We'll also talk about OCD, and it's one of the 10 leading causes of disability. Patients with OCD will experience significant impairment in their quality of life with reduction in social, family, and occupational functioning. Because of the nature and potential severity of signs and symptoms and the resultant negative effects on the quality of life, it's usually considered as a major medical condition. They can present with obsessions or compulsions. Obsessions will cause repetitive thoughts, such as feeling contaminated after touching an object, doubting whether the stove was turned off. Can come as repetitive images, such as recurrent sexually explicit pictures, repetitive impulses, such as the need for symmetry or putting things in specific order, impulse to shout at obscenities in a temple, etc. It can also come as compulsions, that's repetitive activities, hand washing, checking, ordering, needing to ask, need to confess, etc. Or repetitive mental acts such as counting, repeating words silently, or praying. There are also drugs that can be associated with anxiety symptoms, and this would include anticonvulsants such as carbamazepine, antidepressants such as SSRIs, tricyclic antidepressants, antihypertensives such as felodipine, antibiotics such as quinolones and isoniazides, bronchodilators, corticosteroids, dopa agonists, herbal medications such as ginseng, NSAIDs such as ibuprofen, stimulants such as amphetamines, sympathomimetics such as pseudoephedrine, thyroid hormones such as levothyroxine, and people who have withdrawal symptoms from alcohol or even sedatives. Medical conditions can also be associated with anxiety symptoms. So it's always important that medical conditions should be ruled out and the patient should not just be thought to have an anxiety disorder. Such cardiovascular conditions, angina, congestive heart failure, myocardial infarction, arrhythmias, endocrine and metabolic conditions such as Cushing's disease, hyperparathyroidism, hyperthyroidism, pheochromocytomas, B12 or folate deficiencies, neurologic diseases such as migraines, dementia, Parkinson's, and all of that, respiratory diseases such as asthma, COPD, pneumonia, and other medical conditions such as anemias, SLEs, and vestibular dysfunction. Now, we'll talk about the management of patients who have anxiety disorders. The first thing you want to do is to investigate these patients. So you want to do a blood sugar test for people who might have type 2 diabetes, a lipid profile, you want to check the cortisol level, you want to do a uric drug screen for patients who you're suspecting have some form of substance abuse, thyroid function tests, if patient has thyroid diseases, and if you suspect that the patient might have this, possibly the patient gives you a history of weight loss or goiter. 24 hours urine VMA, that's for patients who may have pheochromocytoma, especially if there are cardiac symptoms such as tachycardia or hypertension. An ECG or an echo is recommended for patients who have a high risk for cardiac disease or an evidence of cardiac disease. Pulmonary function test for patients who have shortness of breath to rule out the pulmonary disease, and an EEG for evaluating patients where anxiety is suspected to be a seizure prodromal syndrome. So treatment is divided into pharmacological and non-pharmacological psychotherapy. The pharmacological therapy focuses on the three main neurotransmitters in the brain, which is GABA, serotonin, and norepinephrine. So for GABA, we have benzodiazepines. For serotonin, we have SSRIs, and for norepinephrine, we have SNRIs. Benzodiazepines are the best known and most widely used anxiolytics. They act by enhancing the GABA actions at the level of the amygdala and at the level of the prefrontal cortex within the CTSC loop. CSTC loops to relieve anxiety. There are three major types of benzodiazepines. So 2, 3 benzodiazepines. The 1,4 benzodiazepines include lorazepam, diazepam, clonazepam, and oxazepam. They act as anxiolytics. They can cause sedation and muscle relaxants, but they are addictive and can cause some cognitive and psychomotor impairment. The 1,5 benzodiazepam, an example is clobazam, and it can act as an anxiolytic and anti-epileptic. It can decrease sedation. It has low dependence, low muscle relaxant. It can be used in executive groups and can be continued for a long period of time. The 2,3 benzodiazepines bind to the benzodiazepine site in the subcortical area. It doesn't bind to the GABA receptor complex in the cortical areas. And an example is tofisopam. Advantages is like, unlike other benzodiazepines, it possesses an anxiolytic, like other benzodiazepines, it possesses an anxiolytic property, but it doesn't have any anticonvulsant effect. It doesn't have any sedative effect, and most patients are less likely to be addicted to the medication. And while it may not be an anticonvulsant in itself, it has been shown to enhance the anticonvulsant actions of classical 1,4 benzodiazepines such as diazepam, so they can be used together. Selective serotonin reuptake inhibitors. Like we said, serotonin is a key neurotransmitter that innervates the amygdala as well as the all elements of the CSTC circuit. Antidepressants that can increase serotonin output by blocking the serotonin transporter are also effective in reducing the symptoms of anxiety and fear in every one of the anxiety disorders. Widely used SSRIs are fluoxetine, paroxetine, escitalopram, sertraline, and fluvoxamine. The side effects can be stomach ache, increased activity level. It can cause insomnia, agitation, or disinhibition at higher doses. Less often are diarrhea, headaches, tics, twitching, cramps, and sexual side effects. It's usually important that you start at a low dose and increase the dose based on treatment response and side effects that the patient might have. Serotonin norepinephrine reuptake inhibitors are known as SNRIs, and they can also be used for anxiety and alongside with norepinephrine reuptake inhibitors. Examples of SNRIs are venlafaxine, duloxetine, levomilnacipran, while examples of norepinephrine uptake inhibitors are reboxetine, viloxazine, and atomoxetine. Other used drugs are GABA and pregabalin, and they have demonstrated anxiolytic actions in social anxiety disorders and in panic disorders. Others are 5-serotonin 1A receptor partial agonist, such as buciprone. Monoamine oxidase inhibitors, hydroglyvin, antipsychotics has limited evidence and high side effects, but can be used. Propranolol, oxyprenolol, which are also serotonin inhibitors, can also be used to treat anxiety symptoms used in PTSD. The second type of treatment is psychotherapy, and numerous studies have shown the importance of combining psychotherapy with pharmacotherapy in anxiety disorders. The three types of psychotherapy used are behavioral therapy, cognitive behavioral therapy, and psychoanalytic therapy. Behavioral therapy can The types of behavioral therapy used are: one, exposure and response prevention. We'll talk about them, such as systematic desensitization, inclusive therapy of flooding, anxiety management, such as relaxation techniques, yoga, Zen, GPMR, biofeedback, eye movement desensitization and reprocessing, and social skills training. Um, Systemic desensitization usually helps to overcome anxiety based on a classical conditioning, and there are usually three steps. Here, the patient is usually exposed to the cause of the anxiety gradually until the patient can achieve um, can overcome the fear of the cause of the anxiety. So the first step the patient needs to do is to identify the cause of the anxiety and rank it from the least to the most anxiety provoking. Then the psychologist helps the patient to learn a mechanism response, such as relaxation training, and you can also, such as meditation, not medication, sorry, that's a mistake, such as meditations. And then the next step is to counter condition. That's present the patient with the least item of hierarchy of severity. When you present this patient with the least item, you wait for the patient to achieve serenity, and then the second stimulus is presented until the patient can achieve serenity to the last, to the cause, to the problem that is giving the mood. Here, the psychologist puts the patient in a situation where they face their phobia. This is usually done under controlled conditions and use relaxation techniques, so that the subject can attempt to replace fear with relaxation. It can be traumatic, but necessary if phobia is significant. If phobia causes significant disturbance and affects the patient's quality of life. It's quick and effective, but there's possibility of fear spontaneously reoccurring. So, for example, if a patient is afraid of driving in cars, for example, you can take the patient round, do a trip with the patient for several hours until that patient is able to understand that this activity will not cause any severe damage to me, and eventually fear will be replaced with some form of relaxation. The next one is biofeedback, and this usually involves the mind-body technique using visual or auditory feedbacks to gain control over involuntary or autonomic functions, such as the BP, respiratory rates, and heart rate. It helps with anxiety, and an example is the respiratory biofeedback. Sensor bands are put around the chest and the abdomen to monitor the breathing rate, and it helps the patient to have control over breathing rates in situations that can help in situations which can in turn help to alleviate anxiety. So here, most times, what I use are sensor bands that help to let the patient know maybe when the blood pressure is going up, when the muscles are tensed, when the heart rate is going up, and all of that, so that the patient can develop some form of the patient can develop some form of mechanism to help to reduce anxiety in the patient. Eye movement desensitization is an untraditional method of psychotherapy and is mostly used in patients who have PTSD. It doesn't rely on talk therapy or any medications. Rather, it uses the patient's rhythmic eye movements to dampen the power of emotionally charged memories of post-traumatic and allows the patient to follow the movement with their eyes, including emotions and bodily sensations that go along with it. Gradually, the therapist will move to more pleasant emotions using some alternative finger movements or hand tapping or music tones. It can weaken the effect of negative emotions with hopes that disturbing memories will be less disabling. It's usually a safe therapy with no negative side effects, but it may not always be effective. Cognitive behavioral therapy deals with control of automatic thoughts, correction of cognitive errors, and breaking the association between event cognitive arousal and maladaptive behavior. So it's a form of psychological treatment that has been demonstrated to be effective for a range of problems, including depression, anxiety disorders, alcohol and drug use problem, marital problems, etc. And CBT has been demonstrated to be as effective or even more effective than other forms of psychological therapy or even the use of psychiatric medications. There are three core principles in administering CBT, and one is recognizing that psychological problems are based in part on a faulty or unhelpful way of thinking, and two, they are based in part on learned patterns of unhelpful behavior, and three, that people suffering from psychological problems can learn better ways of coping with them, thereby relieving their symptoms and becoming more effective in their lives. So the treatment usually involves effort to change the thinking patterns of the patient, and these might include learning to recognize one's distortions in thinking that are creating the problems and then to reevaluate them in the light of reality, gaining a better understanding of the behavior and motivation of others, using problem-solving skills to cope with difficult situations, and learning to develop a greater sense of confidence in one's own abilities. It also involves efforts to change behavioral patterns, and it might include facing one's fears instead of avoiding them, using role playing to prepare for potentially problematic interactions with others, and learning to calm one's mind and relax one's body. The last type of psychotherapy is psychoanalytic therapy. And psychoanalytic therapy is one of the most well-known treatment modalities. The goal of this therapy is to help the patient to understand that help the patient understand the unconscious forces that play a role in their current behavior and their thoughts. Psychoanalytic therapy looks at how the unconscious mind influences thoughts and behaviors. And it frequently involves looking at early childhood experiences in order to discover how these events may have shaped the individual and how they contribute to current actions. The therapist will generally spend time listening to the patient talk about their lives, which is why this method is often referred to as the talking cure. The therapy after listening will now provide, the therapy provider will look for patterns, or significant events that play a role in the client's current difficulties. And psychoanalysts believe that childhood events, unconscious feelings, thoughts, and motivations play a role in mental illness and maladaptive behaviors. However, sometimes patients may find that psychoanalysis can be quite intense and personal because it involves a great deal of past experiences, relationships, and feelings. This can lead to a feeling of discomfort as unconscious forces are being brought to light. It can also be a great way to gain insight and deal with the feelings that are difficult to put into words. This type of therapy, some critics claim that this type of therapy is too time consuming, it might be expensive, and it might be generally ineffective. So in summary, for people who have generalized anxiety disorders, the first line is to put them on SSRIs and benzodiazepines. You can put them, second line might be to commence them on tricyclic antidepressants, while as an adjunctive, you do a CBT therapy. People who have social anxiety disorders, first line is to put them on serotonin norepinephrine reuptake inhibitors. Then you can put them on monoamine oxidase inhibitors, and then as an adjunctive, you can commence them on cognitive behavioral therapy. People who have PTSD, you want to start them on SSRIs and SNRIs. Second line, always commence them on cognitive behavioral therapy. These are my references. Thank you.
Oh. Thank you, Dr. Jimba, for the presentation. This topic is very important, Sham. I like that you presented it because
wonderful presentation.
Yeah. Yeah. So the topic is important, Sham. I like that you presented it because it's most of the patients in GOPD present with this, especially in times of this COVID era. So it's an important topic because it's underdiagnosed in GOPD. So it's good you presented it.
Yeah. the patient come with these symptoms and we just try finding out where the problem is coming from, but it's just anxiety, a form of anxiety disorder. Yeah, so it's an important topic. So do we have questions, Onome?
Let me see. I didn't see nobody posted any questions here, but do we have any questions? I didn't see any questions here on there. Residents, any questions? Dr. IJ.
Okay, IT is like the only resident that
Okay.
have done psychiatric post in here.
And she's going for exams.
And she's going for exams, yeah. So all these things, they come out in
I don't
MCQs.
have any question. No.
Yeah,
Okay.
master of all these things now. By now.
But you at least understood
Amen.
this thing, because in exams at least you're supposed to understand how to differentiate the different anxiety disorders.
Yes.
You should be able to classify it, how to differentiate it, and then also it's good for you to know role of complementary and alternative medicine in management of anxiety disorder. So okay, okay, no. Chief, do you have anything to?
Okay, no, basically, you said it, very important topic, especially this period we find ourselves. With this COVID era, a lot of people having all sorts of, complaints, anxious about their symptoms and coming to the GOPD, complaining of one thing or the other. And then when you find out, dig into their family and social history, you find out there's something really going on. And they are overly anxious about their condition. So I think, like you said, it's really underdiagnosed in the GOPD. So we have to have a stronger, index of suspicion for this kind of cases. We may not just, it may not be in the presenting complaints that the patient comes with, but when they come after interacting with them for a while, you pick out some cues and try to, detect those patients with symptoms suggestive of anxiety disorders. So I'm trying to classify them and attend to them appropriately. Yes, those behavioral therapies, very important, very important. They are best done by the psychiatrist and psychologist. So in our setting, we may not be able to do it in our own consulting room, so we most likely will refer them to the behavioral physician and psychologist. So it's a good topic. Well done, Dr. Jimba. Don't know if anyone else.
Okay, Dr. Matthew said that it is very important, especially in these times, that every patient should be assessed in GOPD when they come in. Just like we said, especially during this COVID time, a lot of patients that were coming in, initially they will come with difficulty breathing.
Yes.
And the people will be afraid, like the nurses will be like, the patient has COVID, But by the time you assess, you now see that the patient is panicking.
Yes,
so
just panic.
Okay. Dr. Nafi said that there's a tool, GAD7, that can be used. No, I don't think Dr. Ruth talked
she didn't
about
mention
this.
That. She didn't mention
but
that.
the GAD7 is actually like an assessment tool for patients who have like a generalized anxiety disorder. Like you scale it basically. So you ask them several questions like, are you feeling nervous? Are you feeling on the edge? Are you not? So with every question, there are 7 questions. I'll post it on the group chat, but there are 7 questions that you ask them over the last 2 weeks if they have felt any of these symptoms, and then you scale it. If they have not felt it, it's 0. If they felt it over several days, it's 1. If they felt it more than half in the days, it's 2. And if they feel it like nearly every day, it's 3. So there are 7 questions basically that you ask them. I'll either add it to the presentation, I'll post it on the group for us to go through it. But it's a scale in which you can use to assess if a patient has generalized anxiety disorder and how severe it might be.
Yeah.
Okay. IJ, take note of this one too. Okay. Dr. Taiwo said, can you talk about
Okay,
separation
Chief.
anxiety disorder?
Fine.
Dr. Taiwo said, can you talk about separation anxiety disorder and
Okay.
what is the age of onset in pediatrics?
Okay, I'm not sure about the age of onset. I'll have to check it up. But separation anxiety disorder occurs usually in children, especially when I think maybe at school age, so preschool or something like that. They get anxious when they are separated
Yeah, preschool.
from their parents. So I didn't really touch on it, Sha, but it majorly happens in children as a result of separation from their parents, which can also affect them in long term.
I think it depends. There are several age groups are depending.
Okay.
Several age groups, I think.
Okay.
Like babies, they are for
Okay.
babies, toddlers, children, teenagers.
Okay.
They are different age.
Okay. Okay.
Yes.
Okay.
Okay.
Thank you.
Hello?
Okay. Hello, Dr. T.
No,
Hello.
Chief Udofe wants us.
Dr.
Good evening,
Taiwo.
sir.
Good evening.
Good evening, sir.
Yes, thank you very much. I want to join others to say that was a very comprehensive presentation. And I think all that we need to know about anxiety disorders have been captured.
Thank you, Chief.
Okay. Thank you, sir. All right. HOD also mentioned some things there in the chat window.
Yeah, she said that we need to read the topic again. A lot of people are affected, including physicians. And she said, apart from the history or questions, you must assess the behavior of the patient in the consulting room as well.
My little problem is how we can put this into our practice, and it is very important.
I think Chief is having some network issues.
Oh, okay.
I think Chief is still talking.
He's still talking.
I'm sorry, I have a network issue. But let me quickly say that it's important that we must, in the diagnosis, it's important for us to emphasize the pre-morbid history of that patient, especially the family social history, very important. And also, the area I also want us to check so that we can also practicalize, because not every time we send this patient to psychologists, they remain with you. Must be able to know what to do with lifestyle and home remedies, because when he leaves, he's going back home. You should be able to help that patient. So when you go, you just Google, you'll be able to see some lifestyle and home remedies for anxiety patients. And you should also be able to know, let this patient know how he can cope and support himself in managing himself, because it is important that you should know this. So two things, lifestyle and home remedies, and then coping and support that this patient needs to, so that when he goes back home, he should be able to care for himself. And most importantly, most of these patients move around. From when you see a patient that I've seen this doctor, he wants to see this and move and move and move. You should also know that there should be some anxiety problem that the patient is having. I think on the whole, there's a lot of thing that is embedded in that presentation. For exam purposes, the classification, the pathophysiology are very, very important, so that because those are areas that you can always get the MCQs and the rest of things. I don't know, because each and every one of us must be able to master some psychotherapists. You don't need to be like a psychologist, but you should be able to. And one of the things I've come to realize that most of these patients come in with being anxious about a particular thing. And if you can be able to do your fifth and identify the fears, you can be able to pinpoint it and then manage it clinically by ensuring, letting the patient know, look, this thing is not there, and be able to help the patient. I also noticed that I don't know what happens, whether the slices are not numbered, because some of these things I would have been important with numbering of the slices. Maybe I just want to, you have a template. Even if you have a template that you use, you can always make some changes and put the numbers. On the whole, I think it's a good presentation. Thank you. I hope you've heard me at all.
Yes.
Yes.
Yes, sir. Yes, sir.
That's good. That's good.
Thank you, sir.
Okay.
Thank you, sir.
So please, that coping and support. For example, let the patient make sure that he keeps to his plan. And he should leave the past. You know, dwelling in the past is that if he knows that, look, this is his step now, he may not be able to continue reflecting. Those are things you can do in your own consulting room. Lifestyle changes, you know, having good sleep, you know, good food, you know, avoiding alcohol, and all those things should be part and parcel of this. Because if you look at all the disorders, they seem to have almost the same way to manage them. Therefore, most times it may not even be possible for you to identify this. They almost have almost the same way of managing them, psychologically or psychotherapy and medical by pharmacology. Okay, thank you.
Thank you, sir.
Thank you, sir. Any other questions?
No, nothing. No, nothing. Dr. Jimba, thank you for the
Well done
presentation.
again.
Thank you.
Clap for you again.
Well,
Thank you, Chief.
Thank you. Thank you.
Thank you.
All right, so we're ending the meeting now, right?
Yes, we can.
Good night.